get started, and I want to thank Amy and Claudia for giving me the opportunity to introduce my good friend, BJohnson, who needs probably no introduction to some people here. Becky's a Minnesotan, and she was born in Slayton, Minnesota, and I don't know where that is, not being a Minnesotan.
We'll find out.
But she went to undergraduate in medical school in Illinois. She graduated from Southern Illinois University School of Medicine. And I should note she was named the Distinguished Alumna of the Year there at SIU in 2010, only one of her numerous awards. She did her pathology residency on the East Coast at Bay State Medical Center and at Hartford Hospital, and went on to do a Hematopath fellowship at Hartford Hospital also, and then stayed to work at Hartford Hospital for several years, brief stint at Rhode Island Hospital, and then moved on to become the professor and chair of the Department of Pathology at Berkshire Health System Clinical Laboratories and Department of Pathology, where she was also the residency program director and the medical director of the Medical Technology School there. So Becky is boarded in APCP, in Hemapath, and in Immunopathology, and she has been active in a very large number of pathology organizations, very active in the College of American Pathologists, president of the CAP Foundation, active in the AMA, on the board of the ACGME. And Becky joined the American Board of Pathology as a trustee of the board in 2002, I think it was. And that's when I met her, because I was on the board at the time, and Rob McKenna, Jeff McCullough, and Des Burke, the Minnesota contingent, along with Juan Rosa, who I think overlapped, were all members of the board at that time. And Becky went on to become president of the board in 2009, and then in 2012, when she finished her term on the board, she took over from Betsy Bennett as CEO of the American Board of Pathology, which delighted all of us very much. I should parenthetically mention that when Betsy came on the board, she was engaged to Michael Kelly, who we all adopted immediately as an honorary board member, even though he is not a pathologist. And Michael and I are Facebook friends, so I find out frequently what Becky and Michael are eating for dinner or what they're doing, which is how I keep up with her numerous travels. But we're delighted to have her here today. She's going to talk to us about a very important topic for all of us, and particularly the residents, maintenance of certification. So thank you so much for coming.
Well, thank you, Debbie, for that kind introduction. It's really nice to be back in Minnesota. My family is here, so it's coming home for me. Even if you'd had snow, I would have been just fine with it. So, well, again, I feel like I'm back among friends. So we're going to talk about MOC today. You've heard the introduction. I have nothing to disclose. So these are the objectives for our talk today. We're going to talk about the components of the MOC program, some very exciting recent changes to the program, dispel some of the myths and fears that people have about MOC, and hopefully at the end you'll recognize the value of MOC, and perhaps some of you that are lifetime certificate holders might even think about voluntarily enrolling in MOC. I am in MOC. All of our trustees are enrolled in MOC. How many of you out there are enrolled in MOC, participating in MOC? Okay, good. We are giving our exams right now. Monday, Tuesday, we were giving exams in Tampa, and now we're actually offering them remote, so that's exciting. Okay, so maintenance of certification evolved out of recertification. The American Board of Medical Specialties is the umbrella organization for the 24 specialty boards, and they, as an organization, agreed that that the board should have recertification process. So we had a process for many years of voluntary recertification, but then that morphed into maintenance of certification with the idea that taking an exam once every 6, 8, or 10 years probably isn't really enough for continuing professional development. So it should be more than an exam. And it really comes down to professionalism. You know, the definition of a profession is a group with a body of knowledge that gains public trust and in turn is self-regulating. And it is important that we are self-regulating as a profession in medicine. It's the old saying, if we don't do it, somebody's going to do it to us. And just think about the CLIA-mandated cytology proficiency testing. Not a good thing. And we are probably the only specialty in medicine that has federally mandated oversight of what we do. And years ago, there was actually talk in Congress about we have to have oversight of physicians. So again, MOC is, at least in pathology, it's a pretty good program once you hear of the components of it. Internal medicine has kind of thrown many of us under the bus by some of the things that they have done recently, but I think they will get back on track. So I'm sure all of you are familiar with the 6 ACGME and ABMS adopted core competencies. And as boards, we've been asked to incorporate all of those competencies and assessment of all of those competencies into our maintenance and certification program. So I'm going to talk first about the components of maintenance certification. So part 1 is professionalism and professional standing. How do we assess professionalism? It's not an easy thing to do. It's the old, like pornography. You know it when you see it, or you know when there's a lack of it. But that's something that we are working towards, is figuring out how to do a better job of assessing professionalism. Currently, we rely on having our diplomates have a full unrestricted license to practice. We also ask them to document their medical staff membership and their privileges, or submit a description of their practice. For example, our forensic pathologists, who often don't have hospital privileges. And that has to be reported to the board every 2 years. They need to upload their current license. Part 2 of maintenance of certification is the lifelong learning and self-assessment. So our board requires that our diplomates have 70 Category 1 CMEs over a 2-year period of time. And when we developed the program, we looked at what most of the state licensure requirements were for CME and kind of took the middle of the road as to what we would require. 20 of those 70 CMEs must be self-assessment modules, which essentially means that you have a learning activity and then you take a post-test that demonstrates that you actually did learn something from that. We approve SAMS providers. We don't approve every single SAMS offering, but we are beginning to audit those and trying to improve the quality of those. I'm sure some of you who have taken SAMS, you've seen a lot of variability in how good the questions are or are not. So all SAMs are also Category 1 CME, but not all CME are SAMs. So just keep that in mind. The good thing about our board, I think that keeps things clean for us, our board offers no MOC products except the exam. So some of the boards create MOC products and then require their diplomates to purchase them. So we don't have that conflict of interest, which is good. We rely on our professional organizations to offer the CME and also the Part 4 things. So just as with the licensure, this is reported every 2 years, and that starts after the year of initial certification. So if someone is certified in 2016, their 2-year cycle starts 2017, 2018. We do give credit to diplomates who have completed a fellowship, so they get a buy for 2 years on the MOC Parts 2 and Part 4. And also the board has just recently approved a physician scientist pathway. So if a diplomate is enrolled in the physician scientist pathway, we also give them a buy for their first 2 years of MOC. We, like all the ABMS boards, we require our diplomates to do a patient safety course, and there are currently, I think, 3 or 4 that are available and approved by our board. And we do random audits of Part 2 activities. Mostly we accept attestation. We trust that people are being professional, telling us what they really did, but we do reserve the right to audit. Part 3 is what everybody hates. It's the assessment of knowledge, judgment, and skills. People are very afraid of this exam. We are required to have a proctored secure exam. When we were developing our MOC program, we tried to convince ABMS that we should be able to have an open book exam because it reflected the way we practice. You know, we have access to information. But they said, no, you can't do that. So, because we are so varied in what we do in pathology, we developed modular exams. And we have currently over 90 modules. No other board has tried to tailor the exam to a diplomate's practice more than pathology has done this. We require one mandatory 50-question module in the area of a diplomate's primary certification. So if you're AP-CP, you take a 50-question module that has approximately 20 AP questions, 20 CP questions, and 10 management, administration, patient safety type questions. And then the diplomate can choose 4 additional 25-question modules. They can select them, and I'll show you the variety of modules that we have. Also, what we realized early on, before we started giving the exams, is that, say I'm board certified in hematology. So when I go to take my MOC exam, what am I going to do? I'm going to have to take the 50-question mandatory AP-CP, but then I can elect to take 4 25-question modules. Well, what am I going to select? I'm going to select the Heme-Path modules, right? The Heme modules. And then I'm going to have to turn around and take a 150-question exam in Heme-Path. So what we realized is, you know, that's so redundant. So let's allow people who have subspecialty certification to take their 50-question mandatory module in their primary area of certification, combine that with a 150-question exam in their subspecialty, grade it as a whole, and be done with it. And, you know, really reflect their practice. We shouldn't be testing people on things that aren't important to what they do, although it's pretty hard. We just started giving the MOC exam on Monday and Tuesday in Tampa, and our new system allows the diplomates to comment on every single question. And there was somebody there that, looking over her shoulder, she kept putting, this question isn't relevant to my practice, this question isn't relevant to my practice. You know, we can't make every single question perfect for everyone, short of letting them select their own questions. So also some of the subspecialty exams are modular. We made a decision early on to not have any glass slides or virtual microscopy so that we would be able to administer the exams off-site. Our modules are approximately 80% practical, 20% written, and again, they're all combined and graded as a single exam. As I tell diplomates, the MOC exam is very different than the primary certification or initial certification exam. Initial certification is a high bar. You know, it's your entry into the profession. It's a very difficult exam, and rightly so, because as a board, we have an obligation to protect the public. But once someone has met that high bar and they are a diplomate in the American Board of Pathology and they're keeping up, MOC should really just be an assessment of are they maintaining the important current knowledge and core knowledge that they need for safe and effective practice. So the MOC exam is very, very different than the primary certification exam. It's much more practical. What we like to say is walk around knowledge. We also allow diplomates to synchronize their Part 3, their exams, to their initial certification. So again, if someone was certified in AP-CP in 2015, did a fellowship and was certified in cytology in 2017, they can combine and be on the same track for reporting. We allow diplomates to begin to take the exam in the 7th year after their initial certification. So they have 8 potential opportunities to take the examination. And then the clock doesn't necessarily reset, but if they do take it in the 7th or 8th year, they can have no more than 12 years until they take their next exam. But as I tell people, by the time you're scheduled, if you're taking the exam now, by the time you're scheduled to take it again, we're probably going to be doing something very different than this exam. So, and the fee went up this year because we are offering remote secure testing. So it went from $500 to $700. ABMS did a survey of all of the 24 member boards, and our board is the least expensive for MOC of any of the boards, and we'll talk about the dollars. And of course, that $700 covers multiple exams. As you know, about 50% of residents now are taking 2 fellowships. So we have people that come in and they're taking molecular pathology and hempath, or combinations of those things. So people say, well, why do I have to come to Tampa? Well, initially, we continue to have conversations with Pearson VUE and Prometrics and the test centers, but they will not guarantee the quality of their monitors, and our exams are very image rich. So, they complain enough about the images already without having, a bad monitor, a poor resolution monitor. So, but the good news is that starting on Monday, we began offering remote secure testing. And what this involves is that the diplomate logs in. Actually, they do a system check about 2 weeks in advance so that they're sure that all their equipment is going to work and that they can get into the system. They have to have a camera, so either on their laptop, as many of them already have a camera, or they can buy one of these little handheld things. They have to scan the room, scan their desk, and then the camera records them during the entire time that they're taking the exam. And this is reviewed by a company called Software Secure, and they look for what they consider irregular behavior. They see something that looks like irregular behavior, they report it to the board. We would review the videotape and determine whether to invalidate that diplomate's examination. So we're in our first go on this. As of yesterday morning, we had 30 people already who have completed the remote secure testing. We have about 270 more that will be taking it over this 2-week window period of time. But our diplomates are very happy about this because they don't have the expense and the burden of having to come to Tampa and time away from work. So it's we're very excited about it. It's been a big investment by the board to do this. We're probably losing money on doing it at this time, but we think it's important for our diplomates. We did a pilot. Oh, I'm sorry. This is the very exciting thing. So think about it. To do a 150 or 200 question exam once every 10 years, are we really doing a good job of assessing someone's knowledge, judgment, and skills? Probably not. So the American Board of Anesthesia 2 years ago started doing something very innovative and very interesting. And they call it their MOCA Minute, MOC and Anesthesia Minute. And the volunteers who participated in this program every Monday morning would receive an email from the ABA, and it would allow them, it gave them a link to go answer a question. And they could click onto that link anytime during the week. They didn't have to do it Monday morning, but they had the week to do it. Once they clicked on that link, they were presented with a question, and they had 1 minute to answer the question. And then they were also asked how sure were they of their answer, and how relevant was the question to their practice. Once that was done, they got immediate feedback as to whether they got the question right or wrong. They were given a critique that told them why the right answer was the right answer, why the wrong answers were the wrong answer. References, they could comment on the question. So the idea with this is that it is a formative learning process. So you're learning while you're showing your proficiency and knowledge, and at some point they feel that psychometrically they will be able to make a summative decision. So if someone performs well enough on their MOCA minute, they will not have to take the exam. And this is where we are moving. It's really much more in line with adult learning theory. So we want this to be formative. They learn while they're participating in the MOC, but we also think that we will be able to make summative decisions as to whether somebody does have the requisite knowledge. And we'll find that out a lot sooner. The psychometricians say, you know, if you give at least 200 questions over a 2-year period of time, you can have a pretty good idea as to whether that person has the requisite knowledge or whether they have some significant gaps. So we'll be able to give feedback to diplomates much sooner if they are having problems with their medical knowledge. The challenge for us is that pathologists are so varied in what they do, and to be able to develop questions that are going to be initially relevant to everyone is going to be a real challenge. And the questions will be randomized as to what is sent out. If someone gets a question wrong, several months later they will receive another similar question to see if they actually did learn from getting it wrong the first time. So we think that this kind of longitudinal assessment makes so much more sense and will be much more meaningful and well accepted by our diplomates rather than a once every 10-year exam that everybody's afraid of. And it has a name. It's called CertLink, and we are partnering. We are one of the first 4 ABMS boards in the initial cohort working with ABMS to develop this. ABMS is actually going to own the platform on which this will be administered, and diplomates will be tracked, but it will be all our information. So these are the modules that we currently have. These are the 25-question elective AP modules, and you can see in the popular areas like cytology, SurgPath, breast, GI. We have 3 modules in many of those areas. And continuing on, again, many modules. We have over 90. And those AP modules can be selected by someone who is certified AP-CP or AP only. We also have elective CP modules, and these are the ones. We have fewer people selecting the CP modules than the AP modules, as you would imagine. And again, anyone boarded in AP-CP or CP only can select these modules. And the diplomate can take all AP modules, all CP modules, or we have what we call our common AP-CP modules, which are the sort of crossover areas like hematopath, flow cytometry, infectious diseases, lab management and informatics. We have a medical director module and a patient safety module. So subspecialty exams, those are 150 question exams, and these are the subspecialties that have no modular exams. So it's a single 150 question examination. In hematology, which, by the way, we have now changed the name beginning in 2016, it will be known as Hematopathology. We received approval from ABMS for a name change, so it better reflects what we call ourselves. So in Heme, there's a 50-question mandatory module, and then there are multiple elective modules. So again, we're trying to gear this to reflect an individual's practice as much as we can. In molecular genetic pathology, they have a 75-question mandatory module, and then a number of elective modules that they can select. Neuropathology, they have a 50-question mandatory module, and then multiple other modules that are that a diplomate can select. And PDPath has a 100-question mandatory module, and then they can choose any one of 3 elective modules. Just to give you the history of how we've been doing on our MOC exams, you can see the number of people who have taken the exam, and 3 out of 4 administrations we've had a 100% pass rate. We probably intentionally wanted to make these exams very practical, very basic knowledge, because in part we wanted to remove the fear of the exam. But also, again, I've told you the philosophy that we have, that if an individual is keeping up, they should have no problem with the exam. We also publish on our website very comprehensive study guides for every single one of the modules. So a diplomate can go there, they can see what the content that is going to be covered in that module will be, and they can then select their module and study for it. And other ABMS boards have very high pass rates on their MOC exams as well. Part 4 is probably the most important part of MOC, and it's what we call improvement in medical practice. Our Part 4 has 3 parts to it. And in designing this, we really looked to CLIA. By the way, I should say, Rob McKenna chaired the very first MOC committee. So if you like it, you know, you can thank him. If you don't like it, you know, talk to him. Yeah. But our MOC has evolved, and our thinking about MOC has certainly evolved over time. But when we were designing the program, pathologists have always been very involved in quality improvement and, you know, lab accreditation. We always think about how we can do things better. So it was very natural for us to do Part 4 and not so burdensome. There are still some of the boards that have not figured out how to do this Part 4 improvement in medical practice. Part of this is every 4 years we do want peer evaluations, because there's no way that we can assess things like communication skills and professionalism, some of those softer skills that we can't assess, but peers can assess. So we ask for 4 peer reviews every 4 years. So the first part of Part 4, improvement in medical practice, since most of us practice hospital or laboratory based, first part is laboratory accreditation. So we ask our diplomates every 2 years to report to us their accreditation status. A second part of Part 4 is proficiency testing, interlaboratory improvement and quality assurance activities, again, part of what we do every day. And then the third part of Part 4 is the individual pathologist's participation in some sort of performance improvement or quality assurance activity. And we require 1 activity every year. Because there are so many things that pathologists do, often our diplomates are reporting multiple activities every 2 years. So for example, we allow the cytology proficiency testing exam to be counted. If you're a lab accreditation inspector, if you do some society-sponsored performance improvements such as the CAP's PIP and PAP programs, you know, where you're looking at unknown slides and answering questions and learning while you're doing, we give credit for that. Also, the patient safety course, which is both CME, but we also will count that as a Part 4 activity. We also learned from other boards that they give credit to their program directors for Part 4 because of their involvement in resident teaching, education, teaching them things like patient safety. So we give credit for that. And then we also allow departments to develop their own improvement in medical practice activities. We have a form on our website that asks them to explain to us what the activity is and how it will improve practice, and those are all reviewed and approved, or we ask for more information or say, no, this really isn't an improvement in medical practice activity. And this has been very helpful, for example, to our forensic pathologists who cannot meet some of these other requirements. So when they do perhaps a weekly case conference, or some of them actually do a daily case conference where the group gets together, they review their findings, we consider that a quality improvement Part 4 activity. So who has to participate? Well, diplomates who are certified in 2006 and thereafter have time-limited certification. So they must participate in MOC. And also if they were certified in a subspecialty in 2006 or later. So we do have some individuals, their primary certification is non-time limited, but their subspecialty is time limited. And that's where we've seen a little bit of drop-off. In the MOC, they say, well, I don't really need to keep my subspecialty certificate since I have my primary certification. And also there is public reporting of MOC status. We aren't doing it on our website yet, but anyone can go to the ABMS website and see what the MOC status of a pathologist is, or any physician. So again, the reporting cycles are every 2 years based on the earliest certificate or the enrollment. The deadline, because we know everybody's busy at the end of the year with holidays, we do allow the reporting to go to January 1st of the third year. Certificates and reporting can be synchronized, and also both Part 2 and Part 4 activities are meant to reflect your practice. So if you have a primary and a subspecialty, you don't have to do double CME and double Part 4. We accept just whatever you do to satisfy the requirements for both certificates. And if MOC requirements are not met, your certification lapses. In our case, the lapse takes place at the end of that third year. So we do give a year grace period to report MOC activities. If at the end of that third year they are not reported, that diplomate is no longer certified. And of course, we try to keep in contact with our diplomates, but often they don't keep current email addresses with us, and that's how we communicate. And so it's not uncommon to get a call from a former diplomate saying, I just found out I'm no longer certified. And it usually happens when they come up for being re-credentialed at their institution, and the credentialing office looks them up and finds out that they're no longer certified. We do allow them to get back in though. We also, a difficult decision that we made was that, is that we require our diplomates to maintain their primary certification. And perhaps we were somewhat parental in doing that, but what we find is that diplomates call us and they say, for example, if they were certified AP only or CP only, and they call and they say, oh my gosh, you know, I'm certified in AP and I'm looking for a job and everybody requires me to have CP. How can I get my CP certification? Well, you're going to have to do more training. So, so what we realized is if we allowed our diplomates to keep just their subspecialty and not keep their primary, they could really be hurting themselves in the future and not realizing it. So again, we're trying to make it very easy for people to maintain their primary while examining them on what their subspecialty is primarily. So we do give a 3-year grace period from the time someone's certification lapses and they're no longer certified. We give them 3 years in which they can make up all of their MOC activities and regain certification. After 3 years, you got to take the exam again if you want, the initial certifying exam. And of course, nobody wants to do that. So the take-home message is keep your certification. Ask, well, what happens if I fail the exam or lose certification? Well, on the exam, there are 8 potential opportunities to pass. We provide detailed feedback on the items that all diplomates get wrong. So even if they pass, they do get very detailed feedback. They can submit a plan for remediation or retraining. And again, they have a 3-year grace period to make up the MOC requirements and get their certification back. And then of course, there's always an appeals process. So what about our non-time limited diplomates? Well, we certainly encourage them to participate in the MOC, and you as leaders should really think about doing it now that you know it's not an onerous process. We don't require our lifetime certificate holders to participate. The good news is participation in MOC in no way jeopardizes your lifetime certification. So if you want to do MOC for a few years and then you decide, well, I don't really want to do this anymore, dropping out in no way jeopardizes your certification. Once you enroll, you have the same reporting requirements and deadlines as our time-limited diplomates. So if you joined MOC in 2016, you would begin reporting at the end of 2018. Oh, also, there are, I believe, 11 states that have the 10-year rule. Does Minnesota have that? Where every 10 years you are as a requirement for licensure, a physician has to take a secure examination every 10 years. So for those individuals, and we've had some of these, who are non-time limited, They can come in, they can take our MOC exam, and then begin their MOC process, because obviously we want them to be able to maintain their medical licensure. And much better to take our exam than to take a SPECS exam or take USMLE Part III again. Nobody wants to do that. So again, if someone drops out and then they decide they want to come back in again, obviously that's not good to be in and out and in and out, so we make them make up their MOC requirements. What we're also finding is that third-party payers are starting to look at MOC and seeing the value of that. And also institutions are beginning to require that all their physicians participate in MOC. So Mayo Clinic actually requires all of their physicians to participate in MOC. University of Virginia also requires all of their physicians in MOC. So I think that's a trend that we're going to see again coming forward. Also, ABMS has done a nice thing for diplomates, and they have gone to the states and gotten states to accept participation in MOC as meeting the CME requirements for licensure in the state, and they continue to try to work on states to get that, that sort of double advantage. We do recognize clinically inactive physicians, and that's defined by ABMS as someone who has not been actively practicing for 2 years. Now, interestingly, our forensic pathologists early on thought that they could call themselves clinically inactive, and then they wouldn't have to do a Part 4. We said, no, you're practicing pathology. You are clinically active. So we ask that be reported, and it does exempt those individuals from having to do any Part 4 activity because obviously they're not practicing pathology. And we ask that we're notified. I don't have completely updated statistics because the end of January was when we expired certification for individuals that had not met their MOC requirements. So I don't have the numbers on lab certificates, the current numbers, and not participating. But we have 10,837 certificates that are time limited, and those are held by almost 7,000 diplomates. And we have a very high compliance rate, in other words, people participating, so we aren't getting a lot of dropout and drop off. And again, most of our dropout has been from those individuals that had a lifetime primary certification but a time-limited subspecialty. So what about our fees? $100 every 2 years at the time of doing your Part 2 and Part 4 reporting. Part 1, 2, and 4, I'm sorry. And that is per diplomate, it's not per certificate. $700 for all exams taken in one session, so spring or fall. We have initiated some late fees because we realized that we needed to make things a little painful for people who don't meet deadlines. And of course, the variable costs are really up to the diplomate, whether they can get free CME or have to pay for CME, and same with SAMs, and also Part 4 activities. If they want to do some of the society-sponsored Part 4 activities, obviously there's a cost with that. So, in summary, diplomates certified in 2006 or thereafter have to participate in MOC. MOC is open to all of our diplomates and does not put non-time limited certificates in jeopardy. The Part 1, 2, and 4 activities are recorded every 2 years, and the peer reviews are recorded in the 4th year and the 8th year after certification. The deadline is January 31st of the 3rd year. And some of our exams, many of our exams are modular, and we've worked very hard to align MOC requirements with state licensure and CLIA requirements. We have a redesigned website at www.abpath.org, and there's lots of information on MOC there. And if you have questions, you can email us at abp-moc@abpath.org. or questions@abpath.org. Just a few other things. We have a new mission statement that came out of our strategic planning last year, and that is to promote the field of pathology and the continuing competency of practicing pathologists. And we also adopted a new logo last year because nobody understood our original logo, which actually has a very nice story behind it. And you can see that in the back of our booklet of information. It's still there. These are our officers this year. Gary Prokop is our president from Cleveland Clinic. Jim Stubbs from Mayo Clinic, a blood banker, is our vice president. Karen Call, a molecular pathologist, secretary. Sue Furman, private practice doc, is our treasurer. And Margaret Grimes is our immediate past president. And these are our other trustees. We have 3 new trustees in 2016. Dr. Eric Glassy from California, Jeff Goldstein at UCLA, who was in private practice up until a year ago, and Ritu Nayar, cytopathologist at Northwestern. The board has always wanted to keep a balance between academic and private practice pathologists, but it's really hard to identify private practice pathologists that are willing to give the time and effort, or their group is willing to give them the time and effort to be trustees. So if you know private practice pathologists that you think would be good trustees, bring those names forward. We need them. And those are our trustees. So, any questions? Yes, John.
I'll start out, Becky. I enjoyed that presentation, and very important for our residents to hear this because they will fall into the time-limited category. Question I wanted to ask has to do with what role can academic institutions, such as the University of Minnesota, what role can they play in helping practitioners, particularly pathologists in private practice, prepare for the MOCs? Is there anything we can do to do that?
Well, again, we're hoping the exam will go away. And we do have the study guides on our website. So, obviously, providing CME is always good. Yeah. But I don't think you really need to help them prep. What is really needed and doesn't exist is a way for inactive pathologists to get some retraining so that they can get back into practice. We get phone calls all the time about, I was taking care of a sick parent and I haven't practiced for several years, or I had a sick child and now I want to get back into practice, and of course nobody's going to hire me without doing something, and we say, well, maybe you should go back and do a year's fellowship, but a lot of programs don't want to take these older diplomates. That's a real need, is for retraining.
Okay.
Yes, Rob?
Becky, one of the issues I know ABMS was looking at in the past was the fairly large number, not so much in pathology, but other specialties of people that don't have certification. So they don't have a certificate to maintain. And that in subspecialties, particularly like internal medicine, was quite a significant percentage of individuals. Is there anything is that still an unresolved issue, or are there programs that are going to be developed for people who didn't get on?
Well, that's a big issue. That should we allow non-certified pathologists to participate in maintenance of certification program, and that has not been resolved. I don't know of any boards that are currently letting physicians who are not their diplomates participate in their MOC programs. I mean, certainly a non-certified physician could do those activities, but they would not be reported as participating in MOC. But you're right, that is an issue. In pathology, we have a very, very high percent of board-certified physicians. I think we're probably one of the highest. I know we're well over 95%, probably closer to 98% certified.
And a curiosity alluded to internal medicine was going in a wrong direction. Could you share that with us?
Sure. Well, internal medicine had a number of flaws in their MOC program. First of all, they didn't really consider, I shouldn't bash them, but their board is really high-level academicians. who are kind of out of touch with practice, day-to-day practice. And so their program was really quite burdensome. Their requirements were really kind of unrealistic. And they required maintaining primary ABIM certification as well as subspecialty certification. But for their exam, their MOC exam is the exact same exam as their initial certification exam. So, for example, I had an oncologist friend, and he took 4 weeks off to study for his internal medicine exam, because that wasn't what he was practicing, but he needed to maintain his certification. So that was one of the big burdens and costs. The other thing is they developed products for MOC, and they required their diplomates to purchase the products from them, so it was seen as a conflict of interest. And they were required to do things that people did not feel was relevant to their practice. So they had a huge pushback, and by some pretty prominent internists. The fellow that's at Medscape, the head of Medscape, blanking on his name, but yes? Yes, Eric Topol, thank you. He is one of these, and they started a new board, American Board of Physicians and Surgeons, I think it's called, and they're saying that they will recertify people. Well, the problem is if you go with their system, you're going to lose your certification with our board. So I'm not sure that they've really gotten much traction with what they've done. So what internal medicine did is said, oh my God, they suspended a lot of their MOC requirements with no deadline as to when they're going to reinstitute those requirements. And now they're working with their internal medicine community to develop a program that is relevant and practical and meaningful to their diplomates. But of course, it threw a lot of the boards under the bus. We didn't have much pushback, but some of the other boards like psychiatry and neurology, dermatology, their diplomates said, well, if they don't have to do it, why do we have to do it? So that's been a mess. Yes?
Can you speak to the recent introduction of clinical informatics, both as a component of a subspecialty within pathology, as in other medical specialties, but also the change that will be occurring in 2018 when it will switch from practice-based eligibility to a training program eligibility?
Yeah, that's, well, as with any new board, there's almost always a 5-year grandfather period. So that's when the 5 years are up. So if any of you are interested in clinical informatics and wanting to get certified, you need to apply for the exam. There will be some people that will be caught in the transition time. So for example, we require, I'd have to go back and look at the requirements, but we require a certain amount of time spent with a percentage of clinical informatics. So if someone is halfway in